but is used for peripheral arterial disease of the lower extremities, diabetic patients, smokers, etc., that have very bad circulation in the legs. And then they do a bypass in which they make a connection, okay, between the axillary artery and the popliteal artery. And for a while, a patient is going to be, understanding that the distance between the axilla and the popliteal area, should not be a stretch. If I explain this to you, what do you think could be the best option here? What you should avoid?
I think C. D.
Okay. 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 You say B. B as in boy. Yeah.
I see D.
And the why D? Because the seems positions to be left lateral. They don't say which side is left lateral with flexion of the leg. And I think that it approximates, being in supine in a recliner approximates the two areas. Okay. Okay. They say that sitting in a chair is going to make pressure in the area and can produce ischemia in the bypass. The answer is say sitting in a straight chair, because the pressure in a straight chair, sitting in a straight chair, the pressure that makes, okay, this kind of a bypass in the area, the bypass, okay, that is in the popliteal area, which is behind the knee. The popliteal area is behind the knee, is going to make pressure here in the anastomosis, in the connection between the axillary artery and the popliteal artery. The popliteal artery is behind the knee. And they say that sitting in a straight chair make, stress and pressure in the popliteal area, which is contraindicated. I don't think these questions would be, frequent in your English, because it's a very specialized, procedure. The doctor has ordered antithrombotic stocking to be applied to the legs of a client with peripheral vascular disease. Let's say better, peripheral venous disease. Because vascular can be arterial or venous, okay? And you can have peripheral arterial disease or peripheral venous disease. To make more clear, this is a patient that has antithrombotic stocking, the TEDs, thromboembolic deterrent stocking, but let's say that is peripheral, venous disease. The nurse knows antithrombotic stocking should be applied before raising in the morning, with the client in a standing position after bathing and applying powder before retiring in the evening.
A.
I understood A. Okay, I agree. So this is the moment. The rationale for putting the compressing stockings before raising in the bed is because at that moment after rest, the veins are empty. The superficial veins are collapsed. And then placing the stocking that is going to make a pressure in the extremity is going to keep those veins empty, which is the purpose of using this type of stocking. And it's going to make a gradual compression, which move the blood, the deep blood, in this direction, because the compression is bigger here than here. So there is a grading of compression that move the blood in this direction. Should be placed with the patient on bed, okay, on bed. And after that is when the patient can get out of bed. The nurse has just received the chief report and is preparing to make rounds. Which client will be seen first? The client with a history of cerebral aneurysm with an oxygen saturation of 99%, which is okay. The client 3 days post coronary artery bypass graft with a temperature of 100.2, a limit. The client admitted 1 hour ago with shortness of breath, and the client being prepared for the sharp following a femoral popliteal bypass graft. It is another different graft. Okay, femoral popliteal, no axillary popliteal. So what is the one that you see? Is an easy one.
Sí.
C. C is the acute patient by ABC is a priority. Good. A client with a femoral popliteal bypass graft is assigned to a semi-private room. The most suitable roommate for this client is the client with hypothyroidism, diabetic, ulcers, ulcerative colitis, pneumonia. What is the most compatible with this patient?
Sí.
A.
A.
Okay,
A.
the problem,
Hypothyroidism.
this patient has a wound that is sterile, is not infected. And the diabetic ulcers generally are infected. The patient with pneumonia should be until the clarification of the etiology of pneumonia should be isolated because it could be a droplet. And the ulcerative colitis also has diarrhea and could be a sort of infection. So the patient that is definitively not infected and is not a risk for a person with a wound is hypothyroidism. So the best option here of cohorting is cohort is the hypothyroidism. The nurse is teaching the client regarding use of sodium warfarin, which statement made by the client would require further teaching. I will have blood drawn every month. This is okay. After a while, every month is okay. I will assess my skin for a rash. It's okay. I take aspirin for a headache. I will use an electric razor. So the answer is
C.
Remember that
A.
further teaching is something
C.
wrong, no? So,
Sí.
C.
I think it's C.
Yeah.
yes, see.
C.
Oh no, it's D. It's D.
D,
I will use electric razor for shave.
it is
That's
good.
what you should use.
Good. You
It is
should.
good. Yes,
It's
it
good.
is. It is good. And it is good.
It's C.
Good. Yeah.
It's C.
It is bad. Okay. So remember that you are further teaching, you're going to go after the bad. Yeah. And then if you take aspirin as over the counter plus warfarin, then you bleed too much.
Bleeding.
Yeah, bleeding, little bleeding. Yeah. Um, any medication could produce a rash because allergic reaction. Apart of that, some people taking warfarin develop a specific rash produced by the warfarin. And when you have too much anticoagulation activity, then you develop bruises. And so it's okay to check for rashes in the skin. Once the dose of the warfarin has been stabilized, that at the beginning requires more frequent INRs, PT and INR. Generally, when the dose have been stabilized, then the patient can be checked every month. And it's better to use an electrical razor because there is less risk of cutting, okay, injury, okay, with an electric razor than using a blade, using a blade. Trying to pay attention what they are asking, because if you don't understand what they are asking, then sadly you can fail the question. If they are asking further teaching because something bad, something wrong is said by the patient. The client returns to the recovery room following repair of an abdominal aneurysm, which finding will require further investigation. So what is concerning you? What is not expected? Pedal pulse.
B.
Maybe we better read the options, no? Is not smart to read the options, or is not intelligent. Okay, so it's not smart to read the options and to think carefully in the options. Yes, it is smart. I can assure you. Maybe I'm not smart, but people that are smarter than me say that it's smart. Pedal pulse are regular. Urinary output 20 milliliters in the past hours. Blood pressure 108/50, a little low. Oxygen saturation 97%. So you can rule out the oxygen saturation because it's acceptable, and the pulse are regular. So you need to decide between having an oliguria, so less than 30 milliliters per hour, and the blood pressure that is so-so. Okay, so obviously being so-so is not the most important. So yes, the most important is this oliguria. Okay, so this person could be bleeding internally. This person could be hypovolemic, yeah, or this person may be uh, developed an acute renal failure as a consequence or complication of the aneurysm or the surgery. Any way required, evaluation and treatment. A 60-year-old woman comes to her primary care provider for an annual examination. Her last colonoscopy was 6 years ago, and her last mammogram was 13 months ago. The nurse would recommend which of the following screening tests to this lady: mammogram, pap smear, and barium enema, pap smear, Guaiac test, and pneumonia vaccine, mammogram, pap smear, and sigmoidoscopy, mammogram, pap smear, and Guaiac test.
Yes and day.
B.
Okay.
Yes, and boy.
B.
Yeah, B as in boy. Okay,
Mm-hmm.
pneumonia vaccine is
Yes,
given
B.
at 65. She's only 60. So it disqualified this option. She has
Yes
a
and day.
colonoscopy 6 years ago, so she's colon cancer is okay. So bearing enema is necessary, and sigmoidoscopy is not necessary. But she has more than 1 year since her last mammogram. She has not mentioned a pap smear, so it requires pap smear. And the Guaiac test, fecal occult blood, should be done every year. So D as in David is the best option of the 4. Why not bearing any sigmoidoscopy? Because she has something better, colonoscopy, and it's updated. Is every 10 years. Okay, and as I said, the pneumonia vaccine at 65. A patient is receiving an intravenous potassium bolus infusion stat ordered for hypokalemia. The cardiac catheterization lab calls for the patient to be sent for a cardiac catheterization. Maybe he has a problem in the coronary, has a problem in the heart. Okay, a nurse should do which of the following: stop the potassium infusion and restart when the patient returns to the unit. Notify the prescriber that the patient is leaving the unit on IV potassium infusion. Send the patient to the lab with the infusion along with an LPM. Notify the lab that the patient will be sent after the completion of the infusion. What you do if the cardiac lab is calling for the climb and the patient is receiving an ordered infusion of potassium. Which is a situation of the real life.
D. D.
Okay, say D. Okay, I support your decision because it's very simple. Why the patient is receiving potassium? Because it has hypokalemia. Okay, so the doctor ordered a potassium for hypokalemia, and the patient is receiving that. Okay, the patient needs a test, a diagnostic test, but what has a priority? The hypokalemia or the diagnostic test? Can the diagnostic test wait? Yes, can wait.
Yes.
Okay, so what you need to know is a nurse should not administer potassium intravenous without supervision. So if you stop the potassium infusion because you cannot send the patient to cardiac catheterization without supervision and restart the potassium when the patient returns after the catheterization is bad. Why? Because in this interval, the hypokalemia can kill the client or can produce an unnecessary emergency. Notifying the doctor is not enough because you are not supposed to send the patient without supervision, receiving potassium. The doctor can do nothing in this case. Delegating to the LPN something so delicate like the IV administration of potassium is not the ideal. So the best is to fulfill the doctor's order of giving the potassium bolus for the hypokalemia, and after the patient is stable without hypokalemia, sending the patient for the catheterization, the diagnostic test, and the best option is the as you choose. Okay, so obviously this is the rationale of this question. A triage nurse in the ED is assessing for polytraumatized clients involved in a motor vehicle accident. Which patient is a priority to be seen? So it's a redundancy here, but it's a priority. A patient with a bleeding scalp laceration, a patient with an ecchymotic hip and leg short.
Eso lo vas a romper y se va a abrir ahí y vamos a tener problemas. Por favor.
Ok, está bien. Mute your microphone. A patient draining serosanguineous liquids or lindo, from the right ear, a patient who is complaining of flank pain on the right side. What is the priority here?
Sí.
Okay, what about the patient who has pain?
I think it's D.
Pain in the abdomen, in the flank. Okay. Obviously, this is a hip fracture.
Professor,
Can wait.
Professor, you
Yes.
said, what about the patient who has pain in the abdomen? But it doesn't say pain in the abdomen. Are we supposed to assume that's what it's
What
talking
is the
about?
flank? What is the flank? What means flank?
Okay, I understood.
Okay, flank is the side of the abdomen. Okay, thoracoabdominal area.
No, I kind of just took it as on the side. I wasn't thinking about the abdomen though.
Yes. So remember that all these part that we have in our side is called the flank. Okay, the flank. Okay, the flank. All this is the flank. Okay. So this can be ruled out. So obviously we are good. We are between C and D. So we are good. We are using our critical thinking properly. Okay, those are clients with injuries because trauma. And the one that can wait, okay, are A and B. But then we have somebody with a head trauma and possible skull fracture, and somebody with pain in the side, in the right side of the body. What organs we have in the right flank?
Appendicitis?
No, this is not. We have the liver.
Kidneys.
Okay, and the kidney, the right kidney. Okay, so trying to think in a person. Okay, trying to think in a person. Okay, in a person. Okay, all this area. So here we have the liver, we have the kidney, and the colon. But the appendix is not going to bother us in a trauma, okay? This is going to be something different. It's to thinking that the trauma, the shock, just the trauma could produce problems in the liver, in the kidney, and the colon, producing pain there. You cannot ignore that. You cannot ignore that. It's difficult, the question. These serious sanguineous liquid coming from the right ear suggests basilar skull fracture. And of course, the need of evaluating the brain. And the patient with pain in the flank after a trauma could be liver laceration or kidney laceration. Okay, laceration. Okay, that is difficult. It's difficult. Okay, it's difficult because both patients are, priority. If we go to ABCs, the C supports liver and kidney laceration because it's internal bleeding. If we go to the skull fracture, you need to know that it is accepted that one thing. No, this is too thick. Okay. One thing is the skull. Okay, the skull. The other thing is the meninges with the cerebrospinal fluid. And then deep on this is the brain. Protected by the skull, the meninges, and cerebrospinal fluid. When we have a skull fracture, basilar skull fracture, then the cerebrospinal fluid can flow there. In that case, can flow through the ears or through the nose. A person with a skull fracture can be okay, can be stable, as far as the brain has not been included in the skull fracture. We need to do a halo test to verify that this is cerebrospinal fluid. Okay, to see this test that this stuff is cerebrospinal fluid, and of course make a neurological assessment. Patient go to CT scan of the head to evaluate if there is bleeding or hematoma, etc. It's very different if we say I have a head trauma with or without cerebrospinal fluid, and I have a person that is unconscious, a person that has asymmetric pupils, a person that has evidence of injury of the brain. But they are not saying that there is injury in the brains, only that is a leak of cerebrospinal fluid because obviously there is a skull fracture versus a possible trauma in the liver, kidney. Okay, that are the two organs that could be traumatized in a polytraumatism, an accident, and could be bleeding internally. So I am presenting okay, the possibilities. Okay, so first, what I don't know if this question could be in any test that you could have. Okay, but first, don't ignore the flank. Is the side of the abdomen, and don't forget that in the right side you have the liver, and the liver is an organ that frequently suffers laceration and has very high vascularization and bleeds a lot internally. You don't see the blood. And of course requires determination of vital signs to see that hypotension, tachycardia, exploration of the abdomen to see if there is rigidity, board-like rigidity, rebound tenderness, etc. That could support, okay, the liver trauma. and the person that has a skull fracture should say, the question should give us more information. If the person that is having the leak of cerebrospinal fluid has a normal level of consciousness, an acceptable level of consciousness, I can assure you that a person with eso en concentré, ¿no? A person with what is the neuro 3, the class of, yes, neuro 3, no, donde there is a head trauma. Okay, head trauma. The person that is having a basilar skull fracture.
Professor.
Yes.
That drainage from the air, couldn't that be just like from an ear infection?
Could be. That's why you need to verify that that with a halo test that it is a real, okay, cerebrospinal fluid. That's why I said the halo test must be done before assuming that it is cerebrospinal fluid. Do you see this man? This man has raccoon signs and is leaking serosanguineous liquid. Okay, serosanguineous liquid through the nose. This gentleman had a skull fracture, but the patient is standing and is conscious. Okay, probably drunk, probably drunk from the fight. Okay, and you can have people, leaking cerebrospinal fluid, and doesn't mean that, ¿y por qué este no se me abre? Okay, and doesn't mean that the patient is critically ill, no? You see this person leaking cerebrospinal fluid, you see, and obviously is not unconscious, so not necessarily. Okay, so in reality, I wouldn't be able to help you in a question like this, except to make you aware that is not an easy one, and that a fracture in the skull alone, without compromise of the brain, is not necessarily the priority. A fracture in the skull is just that, a fracture in the skull. And yes, there could be a cerebrospinal leakage, which is important to report because later, hours or days later, bacteria can enter through the same door that has been opened to allow the cerebrospinal fluid to live. And for that reason, it's important to report, it's important to take the precaution. Usually they administer prophylactic antibiotics against staphylococcus, etc. Of course, this patient that has the leak of serosanguineous leak through the ear requires first the halo test. You remember the halo test? This is this test to verify that it is cerebrospinal fluid. Second, a CT scan. But meanwhile, they don't say that there is injury of the brain. They are saying with the cerebrospinal fluid leakage, there is an injury in the base of the skull, in the bone of the skull, not in the brain. This is what says a cerebrospinal fluid leakage. A person could have fracture of the bone of the skull, the raccoon eyes or the battle sign, yes, and leak of cerebrospinal fluid through the nose or the ear, and still being okay. Because this person, as you see, this is standing against a wall, and is it's okay now. It's okay. It's the brain is okay. Okay, but a person with a laceration in the liver could be maybe more acute. So for that reason, I just want to tell you guys, this question is difficult. And this is a question that could challenge you in your Nclex, because majority of us jumped into C, maybe what the Nclex is exploring on you in a similar question. I cannot assure that the wording could be exactly, but the concept is what I want to introduce, is that closed abdominal trauma is a Pandora box. You don't know what is inside, because inside the abdomen, you have a lot of organs that has very high blood flow. The liver is probably the most important. The other is the spleen. Liver in the right, spleen in the left. Remember that both the liver and the spleens are covered by the ribs. Their abdominal organs are below the diaphragm, but they are covered by the ribs. A little anatomy helps. Posteriorly to the liver are the kidneys that also are susceptible to laceration. Close trauma in the abdomen, the force is transmitted to the organs, and the organs suffer ruptures, lacerations are called, and can bleed a lot, So if this question gives me, as I assume is going to be in your Nclex, a little more information. A patient draining pseudosanguineous liquid from the right ear and is conscious. And a patient who is complaining of flank pain in the right side, I first examine D to be sure is not having important signs of internal bleeding, because I'm concerned about the liver. I'm concerned about the right kidney, that both are very vascularized, and a laceration is going to bleed streams, of blood inside the abdomen, and you don't see the blood. But there are signs that make you suspect that. But what is missing here is to tell me that if the patient is conscious, or the patient is standing, or the patient is talking, if the patient is complaining, and the patient is complaining of headache. If the patient is complaining of headache, the patient is conscious. And then I go the patient that is complaining of flank pain. And thanks to your intervention, we had the opportunity of make you aware of the concept of this part of the body that is the flank. That's what I can teach you from with this question.
Perfect. Will be the same concept in case that the question will change, instead of a pseudosanguineous liquid from the right ear, it can say a clear liquid from the nose. It will be the same concept, correct?
The same concept, because both are the same. It's the same fracture. Basal is called fracture.
Got it. Thank you.
So what is the problem with the skull fracture? Okay, a big trauma in the head, obviously. Second, there is a door open that allows the cerebrospinal fluid to leak. But is this an immediate problem? No, it's a problem mediate. It's not immediate. Is in hours. The risk of developing neuroinfection, meningitis. But of course, the priority there in the head is the brain. It's not the meninges. It's not the skull. And if I change the question, if I were using this question for one of my tests, I need to be fair, because I need to win any discussion with a student that is complaining about the question. And I need to say patient draining pseudosanguineous liquid or clear liquid through the right ear or the nose, and the patient complains of headache. To say, okay, the patient is conscious. So what means that the brain, which is the critical organ there, the skull and the meninges are not critical for life. Okay, what is critical is the brain. Once I say the patient complaining of headache, you say, the patient is conscious. So I need to give priority to the patient that is, of course, a liver laceration doesn't affect the level of consciousness, but affect the bulimia. And for ABC would be a priority. Because remember that is still a very valid, okay, strategy to decide which one to see first. In this case, it's the problem of circulation because hypovolemia, internal bleeding are priorities, are emergencies. But if they say in this that the patient has Glasgow Coma Scale 6, it becomes the priority because now the brain demonstrates that is affected. So what I want to convince you is that you can have a skull fracture, God forbid, but you can have a skull fracture, you can be okay, totally okay, with a bump in your head and a lot of headache, but you can be okay because God, nature, precisely that's why God made the skull to protect the brain. And not only the skull, the liquid that is around cushioning the brain and the meninges, you understand? And the issue there is the brain, not the skull. So you can have a skull fracture. Okay, that's it. What is the treatment? Nothing. Rest, observation. Okay. Okay, it's an open, fracture, and there is a leakage of liquid. Okay, antibiotic, prophylactic antibiotic to prevent. Okay, and avoid Valsalva, etc. That's it. This is a very basic treatment. So the problem is not the skull. The problem is the brain. And when they say, draining cerebrosanguineous liquid, assuming that is cerebrospinal fluid, is the skull that is fractured. They don't mention there that the brain is affected. Is my defense of giving predominance to D. Which of the following rhythms would warrant a nurse to hold digoxin? It's too big. Okay. Yeah. I have a way of solving that. Okay. A little more chickadee. Okay. A, B, C, or D?
C as in cat.
Yes. C as in cat, because there is a bradycardia. And each time we get digoxin, we need to check the heart rate, and it is less than 60. We withhold the digoxin. Yeah, 1, 2,
Professor.
3, 4, 5, almost 6. Yes, sir.
Professor, yes. Quick question. Is the apical pulse or the
Apical.
Apical pulse, right?
Apical.
Okay,
Because the radial pulse, remember, that is not credible in, for example, in atrial fibrillation or dysrhythmias. That's why we can have an apical radial deficit. Apical pulse is more precise, is more exact. When there is cardiac dysrhythmias, some beats could not produce enough cardiac output as to produce the pulse in the radial pulse, okay? The jump of this beat. And for that reason, you can have a apical radial deficit. For that reason, to evaluate heart rate in patients with delicate medication like digoxin, or patient with dysrhythmia, with irregular rhythms, need to be apical. This is a sign of, this is a shark teeth. You see that? The saw teeth. Okay, this is an flutter, atrial flutter, the first one. And I recognize that because I remember the movie Shark. Those are the teeth of a shark. Yes. Okay. You can say that is the teeth of a saw. But I think that few of you have ever taken a saw in your hands. This is a normal sinus rhythm, PQRS, PQRS 1, 2, 3, 4. Is a normal sinus rhythm with an isolated premature ventricular contraction, which doesn't require to withhold the digoxin. And this is a patient with sinus tachycardia, PQRS, 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 but the frequency is increased. M is a candidate for digoxin. Is a good. The one that could not receive the digoxin is the bradycardia, because that's why we withhold the digoxin when the heart rate is less than 60. A home care nurse has received call from 4 patients, which patient call should be addressed first by the nurse. A patient with diverticulosis complaining of lower abdominal pain and feeling hot. A patient with glaucoma complaining of sharp pain in left eye. a type 2 diabetic patient who is unable to insert the needle of an insulin infusion pump. A patient in warfarin therapy complaining that it took 5 minutes of pressure to stop bleeding from laceration sustained while cooking. Okay, what do you think about Diaz in David? It is expected. If you are taking warfarin, will take longer to stop bleeding because that's what you are receiving, a blood thinner. Yes, so it is expected. So you need to press longer than usual, but yes, okay, the bleeding stopped. So Diaz in David is a no-no. Okay, it is okay. Okay. A type 2 diabetic patient that is using an insulin pump, okay, and having a problem with the needle, okay, can wait. Can wait. The diabetes is not going to kill the patient from one moment to the next. Can wait. So now I have a glaucoma with pain, and I have somebody with diverticulosis, but could have diverticulitis. So acute glaucoma versus infections in the diverticulitis. What is the priority?
A.
A.
Okay,
Diverticulitis.
everybody is favoring the diverticulitis. Okay, a diverticulitis, okay, how is treated? Okay, yeah, I'm going to tell you, is going the
With
patients with MPO
antibiotic.
or liquid diet and antibiotics.
Okay.
Do you think that it has priority over somebody that is at risk in few hours of losing the eye? So being left one-eyed man. Don't you think that a person with appendicitis, pneumonia, meningitis can wait half an hour and this is not going to make a difference in comparison with a patient with an acute glaucoma, a close angle acute glaucoma, which is the one that produces pain,
B is first.
that is going to produce blindness if it is not cared quickly. So I disagree when you select infections as priorities, because the infections are subacute. Well, the infections are acute, but in comparison with an acute glaucoma, are less acute than the glaucoma. If you are going to have, God forbid, a patient with meningitis, okay, today you have sore throat, malaise, maybe a temperature of 100, okay? Tomorrow you are going to have headache, you are going to have, a temperature a little higher, okay, in the morning. And then in the afternoon, tomorrow in the afternoon, okay, you are going to be a lot of headache, and then you are going to be behaving a little weird, a little confused, a little lethargic, and your family or your friends becomes concerned and take you tomorrow in the afternoon to the ER. Then when you arrive to the ER, they do nothing except initiating droplet precautions and preparing you for a lumbar tap. And once the lumbar tap is done, they get the vein and they start IV antibiotics. So it took like 24 hours. You have an appendicitis. Okay, you have abdominal pain. Initially is in the umbilicus in the morning. And maybe in the afternoon, the pain is much more intense and is more localized in the right lower quadrant. And then you have anorexia. But after, from morning to the afternoon, and then in the afternoon, you decide to go to the ER. When you go to the ER, they say, oh, it looks like an appendicitis. Okay, let's do a CT scan of the abdomen. Let's go, a CBC to see if your white blood cells are increased. And then, okay, because they are abnormal, they call the surgeon for your evaluation. And then in the night, after the pain starts in the morning, in the night, they take you to the surgery. Yeah. In a patient with diverticulosis that start presenting abdominal pain and fever, okay, then they're going to do the same. Okay, you arrive to the ER, and then they make a CT scan of the abdomen, a CBC, similar to appendicitis, and oh yes, you have. Okay, we are going to keep you in a clear liquid diet, and we are going to start antibiotics. But a patient with acute glaucoma, a close angle glaucoma, is a patient that in few hours is going to lose the eye. This is something very fast. It is the same as the retina detachment. With the difference, the retina detachment doesn't hurt, but the acute glaucoma hurts a lot. The pain is intense. The pain is intense, the acute glaucoma. The glaucoma, normally, the glaucoma has the majority of the people doesn't hurt at all. It's something that lasts years until the vision is gradually lost in the peripheral fields, and then you end with a tunnel vision, only seeing the central part of the visual field. But the acute glaucoma is something different. It's also called the close angle glaucoma, in which the person from one moment to the next start with experiencing an intense pain in the eye, and the eye becomes red. The vision progressively in few hours become very blurred until being lost, and the patient vomiting because the intensity of the pain. And this requires immediate administration of mannitol to decrease the pressure of the eye, yes, and a surgery with laser to drain, to make a hole to drain the pressure. And it is a priority. Guys, here the priority is the acute glaucoma. Okay, the acute glaucoma. No doubt of that. The diverticulitis can wait half an hour, okay, while the CT scan result is ready, etc. Meanwhile, the pressure of this acute glaucoma is lowered as soon as possible to minimize the loss of the vision. Patient with acute glaucoma that is not treated properly, they need to do enucleation, need to remove the eyeball. Which of the following patients in the nursery should the nurse attend first? A 2-day-old, 39-week gestation infant with jaundice. A 40-week gestation newborn just admitted from labor and delivery after a cesarean birth. A 37-week gestation newborn with congenital hip dysplasia who is being discharged in 1 hour. A 40-week gestation newborn male who was circumcised 2 hours ago and has not yet voided. Which of these required to be seen first, guys?
D.
C as in cat.
D. D as in
D
dog.
as in David. D as in David. Okay. Okay. 2 hours is not too much. Okay. 2 hours is not too much.
A.
Is not too much. Jaundice that occurs after 24 hours.
I think it's
After-
B.
After 24 hours, jaundice that occurs after 20. Kai, listen to me, conchale. Learn your stuff. Jaundice that appears after 24 hours, okay, is not considered an emergency. It's considered a physiological jaundice. In Nclex, the jaundice that will take you first as a priority is the jaundice that appears before the first 24 hours. So you can, with confidence, rule out this because it's a jaundice 2 days, appear in the 2 days old. It's a physiological jaundice, okay? I admit that the client with circumcision should be observed for inflammation that could obstruct the urinary outflow. But 2 hours is not too much. 2 hours without peeing is not too much. Okay, 2 hours and a dry diaper is not too much, especially after a circumcision. So, but I accept that it is okay. Obviously, I think that everybody rule out, okay, the one that need the teaching for the hardness, okay? But what is the problem of a child that has been just admitted? What is the problem? You don't know how this child is. Could be perfectly okay, or could have a problem. You understand? So you need to learn, you need to take care, well, first for the real life practice, and second for your Nclex, that the child has not peed in 2 hours after circumcision. You can wait. You can wait another half an hour and nothing is going to happen. Nothing important is going to happen. But a child that is just admitted, is coming from a C-section, okay, is just admitted. You don't know how is the child. You don't have any idea. So it's the one that you need to assess first. Because, okay, it's okay. The child is okay. Okay, it's okay. But the child is not okay. The child has a problem. So thanks God, you first, assess the child that you didn't know what had at this just admitted. So the priority here is B as in boy. Understand? D as in David can wait 15 minutes, half an hour, and nothing is going to happen because it's not very alarming that the baby has 2 hours without peeing. Babies don't pee continuously; they pee every certain number of hours. Okay, so definitively the priority here is the just admitted, and learn that a person, a patient, a client that is just coming from the ER to your floor is the first that you need to check, because you don't know what you are receiving. You can be receiving a patient very stable. You can be receiving a patient very unstable. The same patient just admitted from after a colonoscopy. You can be receiving a patient bleeding internally. You can be receiving a patient that has not recovered from anesthesia, and they can be sending you even a cadaver. You need to assess the person that has just admitted, okay, from OR, from colonoscopy, from catheterism, from returning from whatever. It's important. So this concept is tested in Nclex. Remember, the Nclex is not only testing knowledge, it's also testing your common sense, your stuff. And you need your common sense tells you a person that is just admitted, you don't know what has. Okay, because if I put here a 40 years newborn just admitted with cyanosis and generalized cyanosis and respiratory rate 80 per minute, then you say this is the first. Okay, how you know that this is the first? Because you assess the patient just admitted, because you don't know what is coming. The patient that has not yet peed in 2 hours after circumcision, you can wait. Can wait. A nurse enters the room of a patient with chronic obstructive pulmonary disease who is alert and oriented. For which of the following findings would the nurse complete an incident report? The Cerebral on the right side is down. The nasal cannula of the oxygen is lying on bed. 3 pills are in a cup on this nightstand. The patient reports rude behavior by the nursing attendant. What of these requires an incident report, the variance report?
Sí.
Okay, you are good. You are good in this, okay? This is unacceptable. The patient has the right to have the nasal cannula wherever he or she wants. It is autonomy. There is no need in this patient to have the patient, with side rails up. And the rude behavior requires assessment, requires you need to go to the nursing attendant to hear the nursing attendant version, and try to solve this management problem. But definitively what is unacceptable is that a medication had been left at the patient's side without the nurse witnessing that the patient took the medication. If the patient doesn't want to take the medication, you do what you need to do in those cases, and then you remove the medication, dispose the medication, and document that the patient refused the medication, but not leaving the medication there. A team of an RN, LPN, CNA is receiving the shift, which of the following patients required care by the RN. So if they say care by the RN, of course, is probably a patient that is the most acute, the most unstable, the one that requires something that only the RN can do. Only the RN can do. My goodness, esto no se quiere mover. Okay. A 34-year-old whose urine has tested positive for marijuana and cocaine and is demanding his PRN oral pain medication. The patient has threatened to sue the hospital if he doesn't receive medication immediately. A 6-year-old girl brought in by her parents who suspect she might have ingested medication that belonged to her grandmother. The patient responds to painful stimuli, has BP of 80 over 56 years, okay. Heart rate 148, a little high, respiration 10. A 17-year-old boy, 4 days post-open reduction in internal fixation with manifestation of a urinary tract infection and an order for removal of the indwelling urinary catheter. A 45-year-old type 2 diabetic with cellulitis and stasis ulcer of the left lower leg requiring wound care. Which of these 4 patients requires
B.
B as in boy? There's no doubt of that. This girl requires more assessment and requires interaction, communication with the toxicologist. Okay, so this requires the RN intervention. Absolutely. The other one can be managed by the LPN. Okay, so give the oral medication to the demanding patient, remove the foley of the indwelling catheter, and wound care of the diabetic foot. Which of the following patients should be assessed first by a nurse? A cataract post-op patient transferred 3 hours ago complaining of nausea and dry heaving. You know what dry heaving? Yeah.
No.
It's when you don't have anything in your stomach and you have nausea and you start. Yeah, you got the idea?
Yes,
never,
thank you.
Never happened to you? Okay, it's horrible. A patient today is post-coronary artery bypass graft wanting to ambulate. A type 1 diabetic patient who received 5 units of regular insulin 2 hours ago. An elderly patient whose family has been awaiting waiting discharge instruction for 4 hours.
E. A. A. A.
Okay. What can happen with A? Is somebody that have a surgery,
B.
a very delicate surgery. They remove the lens, the natural lens, and they put an artificial lens there in the eye, no, in the eye, and of course, the care, the post-cataract surgery care, include keeping the head elevated, avoiding Valsalva, avoiding straining, avoiding coughing, avoiding bending over. Yes. Covering the eye with a protector during the night to avoid, okay, scratching the eye. If you're sleeping in the lateral position, sleep on the non-surgical side. Okay, so what could happen if the patient start having this it is Valsalva? What could happen with the artificial lens placed in the eye? Can dislodge? If the artificial lens dislodge, need to go to surgery again. This is what can happen in A. Okay. B as in boy is a patient has 2 days of surgery. Okay, and is expected to be already ambulating. Is asking for assistance to ambulate. Can wait. A type 1 diabetic receive regular insulin, peak of action between 2 to 4 hours. Okay, there is nothing here that makes you think that the patient is having an adverse reaction. An elderly patient and the family is waiting. It is something that can wait also. So I heard that the majority went after A, and I support A, because what you need to do in this patient, if the patient has not ordered anything for nausea, you need to call immediately the doctor to prescribe something for nausea, because you don't want the patient doing the dry heaving, because it is Valsalva maneuver. And it's the same as coughing, sneezing, lifting weight, straining. It's the same. You know, if something can produce dislodgement, dehiscence of the stitches, and dislodgement of the lens, the artificial lens that is just placed there into position. That's why the care, the post-cataract care requires, okay, avoidance of those trauma. A patient who receives spinal anesthesia for hernia repair is transferred from the recovery area to the unit. The oxygen saturation is okay, blood pressure is a little high, the pulse is high, temperature is okay, respiration is acceptable. The patient is complaining of incisional pain. What, hernia repair? Oh yes, this hurts a lot. Patient incisional pain 6/10. The urine output is 32 milliliters per hour, and the dressing is dry and intact. The priority nursing action is to place the clients in high Fowler and open the IV line, place the clients in semi-Fowler and administer oxygen, call the physician to evaluate the patient, medicate the patient for pain. What is the answer?
I will say
Yes,
C.
and David.
Correct.
I will
This
think
is
D, but it's 6/10, so not
this is a
completely sure
patient.
about.
This is a patient that is having a sympathetic activation. It's sympathetic nervous system activation after a surgery, and is complaining of pain. So is this pain what is producing this tachycardia and this mild elevation of the blood pressure? This is the priority. The oxygenation is perfect. So why you want to administer oxygen? Why a person with pain in the groin is going to be placed in high Fowler? Do you imagine that? A person with pain in the groin, okay, pain in the groin here, being placed in high Fowler? And why you open the IV line if the blood pressure is high? Doesn't make sense. Yeah. Okay, call the physician to evaluate the patient. And what is going to tell you the physician? Nurse, administer the pain medication. That's why the patient has, okay, has the activation of the sympathetic nervous system, because pain activates the sympathetic nervous system, you know? And the priority here is medicate the patient. You see how when the pain subsides, how the heart rate and the blood pressure goes back to normality. The rest is everything is normal. So you are having all the clues here to know that what you need to do is to administer pain medication. There is not any other deviation of the normality except the pain and the activation of the sympathetic nervous system producing increased heart rate and increase of the systolic blood pressure, which is expected in a person with pain. D as in David. Which patient should the nurse see first? A patient receiving heparin and the PTT is 48 seconds, being the normal time 28. A type 2 diabetic patient with serum glucose level of 210 complaining of urinary frequency. A patient with sickle cell anemia complaining of pain and the hematocrit is 22. How much is the hemoglobin of this patient? Hemoglobin.
6-7.
Okay, 7,
60 and 7.
7,
6-7.
7 point something. Okay.
Okay.
3 times 7, 21. So it's a little more than okay. So it's like 3.7.1. An adult asthmatic client receiving oxygen by face mask with a respiratory rate of 14. So obviously, respiratory rate 14 is okay. We rule out this. And then we don't know how much should be the PTT of a person receiving a heparin with 28. Okay, I need to multiply 28, okay, times 1.5. Ok, 5 por 8, 40, llevo 4, más 14 y 28. 0, 8, 4, 12, llevo 1, 42. 42, 2, 28 por 2.5, 5 por 8, 40, llevo 14, 2 por 8, 16, llevo 1, son 5, 0, 10, llevo 1, 5, 6, 7, 270, 270. Okay, this is the range of desired PTD in a person with control time 28 and the patient is 48. So it's okay or it's not okay?
It's completely okay.
It's low.
It's okay. It's within the
Not risk of
range.
bleeding. No risk of bleeding.
Okay, but the important is that the PTD is in the desired range of anticoagulation. And how I calculate that? The control time, this is always given, is multiplied twice. First, 1.5. Second, 2.5. With the calculator you have in the computer that you're taking the test. Why I said that? Because the school taught me that when we give heparin to a client, we want to prolong the coagulation time from 1.5 to 2.5 times the control time. So 1.5 is 1.5. 2.5 is 2.5. And the control time is given here. And then I multiply the control time, 1.5, 42. And again, the control time, 2.5 times, 70. And then I check if the actual, real PTT of the client receiving heparin is within these two limits, 42 and 70. 48 is between 42 and 70, so it is okay. I just wanted to make you know how to manage, because it's going to be your future. You're going to be nurses and you're going to have patients with heparin, and you need to know how is used the PTD to know if the actual real PTD of the patient with heparin is okay or is not okay. If this PTD is 80 and the patient is not bleeding, but it's not good. So not necessarily you are going to only see if the patient is bleeding or not bleeding. It's not so simple. You need to know that the dose of heparin need to be adjusted up or down. They need to be titrated up or down. Okay, knowing which is when the desired range of PTD in the client. Okay, this is a difficult, stuff, but in reality, it's not difficult. Just remember that the purpose of giving heparin is to prolong the PTT, the controlled PTT, 1.5 to 2.5 times. So it is okay. So now it's between the person with sickle cell anemia who is having pain. What means that is having pain? Is in crisis or is not in crisis?
It's in crisis.
Is in crisis. Is in vaso-occlusive crisis. And the hemoglobin is already in 7. And then you have a type 2 diabetic client with the blood sugar is 210, where it's not so high, and is peeing a lot. Of course that you are peeing a lot. Your blood sugar is high. Okay, so the priority obviously is C as in cat. Yeah, C as in cat. How you know that the hemoglobin of this patient is 7, you need to know that if you divide the hematocrit by 3, you have the hemoglobin. And if you have the hemoglobin and you multiply the hemoglobin by 3, you have the hematocrit. Is in both ways. Which of the following complaints, if made by a client, would require the most immediate nursing intervention? Pain level 4 and 10 in the patient 20 minutes after receiving analgesic for renal colic. Is decreased a lot. Usually the pain in renal colic is 10 on 10. Intermittent sharp pleuritic pain in a patient with a fractured tibia. Numbness in the extremity in a patient with type 2 diabetes mellitus. Frequent loose stools with blood and abdominal cramps in a patient with ulcerative colitis. Okay,
D.
obviously patient.
D.
D.
Okay, D as in David. Okay.
Yes.
Yeah, D as in David.
Okay, so obviously patient A is okay, because if you arrive with 10 over 10 and now you are 4 over 10, you are okay. Okay, so I saw that you didn't consider that numbness in a patient with type 2 diabetes is expected as part of the diabetic neuropathy, is even can have pain at night, so it's okay. And everybody said that frequent loose stools with blood and abdominal cramps in a patient with ulcerative colitis is an emergency, okay? But this is the kind of bowel movement that the patient with ulcerative colitis have. This is the symptom of ulcerative colitis: diarrhea with mucus and blood and abdominal pain. So what about B as in boy? What could be B as in boy? What can produce a fractured tibia, which is a bone here in the leg? What has to do with the pleura, which is a membrane that surrounds the lung?
Pulmonary embolism.
Could be an embolism, a pulmonary embolism. These embolisms can be of two types. Could be a clot, because a fracture, a trauma in the legs can favor the formation of clots in the veins, but also could be a fat embolism. Yes. So now I have something expected: diarrhea with blood and mucus and abdominal cramps in the patient with ulcerative colitis. You need to review ulcerative colitis and Crohn's disease, the symptoms. And a patient will have something unexpected in a fracture, which is symptoms of compromise of the lung. And you need to decide which is more concerning. Okay, so this is the way of approaching this question. Definitively, I give priority to the unexpected, the pulmonary embolism, because the problem is that it continues happening, can be much more severe the next time. The loose poo-poo with mucus and blood is expected in ulcerative colitis. The colon is full of ulcerations, and this is something autoimmune that need to be treated with anti-inflammatory medication and immune suppressors. Under the Good Samaritan law, which of the following cases would a nurse be protected by this law? Applying an ice pack to a child's swollen ankle in a soccer game, pulling an unconscious person out of a car after a collision, transporting a diabetic neighbor who is in a diabetic coma to the hospital, helping an elderly person to get up after a fall at a store. In which of the situation applies Samaritan law?
B as in boy.
Of course, B in emergencies, this level of attention. The others doesn't apply Samaritan law. If something happens in this, and there is no gross negligence, okay, you are protected by the Good Samaritan law. A nurse is emergency situations. A nurse has received report on the following patients, which situation would require the most immediate intervention. A 2-year-old patient with bacterial meningitis in a private room located near the nurse station. An 18-month-old child post-op hypospadia, repaired in a crib with a dome cover, and a 5-year-old child post-operatory tonsillectomy and with very anxious parents. A 65-year-old male patient with varicella zoster in a private room at the end of the hallway. A 28-year-old male patient with bronchitis and 76-year-old male with a patient with diabetes like ulcers in a semi-private room. Okay, which of these 4 situations requires intervention?
D as in David.
I assume that it is correct because A, a patient with meningitis alone, okay, is okay. 18-month-old child, hypospadia, and 5-year-old tonsillectomy is okay. And it's expected to be anxious parents, okay? If we are a parent, you are always anxious if your child is sick. A 65-year-old male with zoster is alone, is okay. So yes, definitively is D as in Davy. The patient with bronchitis should not be with an old patient that also has, okay, diabetes, okay, and ulcer that could be infected, that could be, okay, not adequate for this. So they both are not good to be together. So it's the worst combination. The nurse incorrectly administers carvedilol correct to a client with an order for benztropine congentin, because they sound like similar, no? What is the priority nursing intervention after making this medication error? Notify the nurse manager, complete the incident report, notify the healthcare provider, monitor the client's blood pressure. What is the priority?
D as in David.
Of course, the priority is the patient. And when you administer a beta blocker to a patient that doesn't need it, you have the possibility of having bradycardia or having a hypotension. So first, the assessment of the patient. All need to be done, okay? But they are asking, okay, the priority. The priority is to be sure that the patient is okay, that there is not, okay, consequences of this mistake. All the rest need to be done, okay? Check, communicating the provider, completing the incident report. You should also communicate to the problem to the nurse manager. But the priority is the patient. Good. The nurse is planning a teaching session with a client about a new diagnosis of congestive heart failure. The nurse and the client do not speak the same language. The nurse arranges for an interpreter to be present for the teaching session. Which nursing concept is this action an example of informed consent, confidentiality, quality improvement, client advocacy? Okay, when you don't speak the same language of a person and you find a professional interpreter to do an appropriate, okay, communication, okay, with the patient, okay, what you are doing?
Yes, and Davy.
Correct. You are demonstrating to be advocate for the patient, okay? Because you can be indifferent to that, and then you can be speaking your language. I don't care. You don't care that the patient is not understanding you or you don't understand the clients, and then you can go on, okay? Okay. If you look instead of professional interpreter, you look for a family member or another nurse that speaks the patient language. What could be the issue here? Confidentiality, guys. You cannot use a family member to translate for the patient because maybe the patient doesn't want the family member to know what is happening. You cannot use another nurse or another person, a CNA, whatever, okay? to translate for the patient or for the patient, because it is a person that doesn't need to know what is happening with the patient. Remember that the person that is going to receive the information is the person who needs to know. Who needs to know? The nurse that has the patient assigned, the physician has the patient assigned, and the insurance that have to deal with the patient issues. That's what is HIPAA, okay? Health Information Accountability and Portability Act, okay? So in this case, it would be a problem of confidentiality. But when you do exactly what needs to be done in this situation, a professional interpreter, okay, which is the correct to do in those cases, okay, you are demonstrated your client advocacy. The nurse is caring for a client who had an appendectomy 2 hours ago. Which is the most reliable approach for the nurse to assess the client's post-operative pain? ¿Qué edad tiene? They don't see the age, you know. A client, okay. Ask the client to rate it and describe the pain. Monitor for nonverbal signs of pain, such as grimacing and crying. Check for changes in the client's vital signs, such as tachycardia. Observe the client for behaviors such as guarding, bracing, or splinting the surgical site. What is the answer?
A. Yes.
Of course, what the patient says through his or her mouth is the best of the best assessments of pain. This is the answer. And please don't fail this question in your English. Okay, that's why I was asking for the age, but if they don't mention the age, no, if they say a 1 year old, if they say a patient that is unconscious, of course you cannot do this. Yeah, and then you need to go through the behavior of the pain. That is the guarding, the bracing, splinting, grimacing, crying, and even alteration of the O2 saturation, tachycardia, etc. But those are the behavioral scales for evaluation of pain that are used when this is impossible, But the best of the best to evaluate the pain is just asking the patient how intense is the pain, trying to quantify that in a scale, and asking the patient to describe the pain. Is it stabbing, is burning, is radiating, etc., etc. So this is the only possible answer to this question. Good. The nurse in the ER is admitting a client for pneumonia and sepsis. The healthcare provider has given the nurse orders. Prioritize the order of implementation from highest to lowest priority. Okay, let me see. Okay, what RTH? Start an IV, apply oxygen, give result. Okay, what is the number 1?
D.
Yes, this is the number 1. ABC. This is the number 1. Okay, what is the number 2?
C.
The number 2 is to get a vein and start the IV infusion. The number 3?
A.
A.
A. Number 4?
E. As an elephant.
Yes. And then the last, of course, is stitch. I agree with you. I agree with you. This is the ABC order, okay? At a monthly staff meeting, the nurse manager is discussing quality improvement initiative on the hospital nursing unit, which is an example of quality improvement outcome indicator. So outcome is what happened. Somebody came with pain, has no pain. An infection, has no infection. A fracture, the fracture is solved, etc. So What is an example of quality improvement? Outcome indicator. So something that you can use an indicator that the outcomes have improved in quality in the service. The number of clients who receive smoking cessation information, the amount of time it takes for nurses to administer medication, the percentage of clients who have Medicare insurance, the frequency of postoperative wound infection on the unit. What is the answer?
D as in David.
D as in David.
D as in David. D as in David. Good. The charge nurse observed a new nurse inserting an indwelling urinary catheter on a female client who is experiencing urinary retention. After the nurse inserts the catheters, no urine outflow appears. So obviously, if the woman has a urinary retention, the catheter didn't go to the bladder, probably went to the vagina. Which action should the charge nurse take? Okay, because the charge nurse is observing the nurse doing that. Have the nurse get a new catheter and insertion kit. Ask the nurse to withdraw and redirect the catheter anteriorly toward the pubic bone, where the urethra should be opening, the meatus should be. Remove and re-lubricate the catheter and assist the nurse in the reinsertion. Leave the catheter in place and check for urine output in 15 minutes. What option you choose if you have a question like this?
I would choose A.
A.
And I agree with you. It's the only option that is not using the same catheter. And leaving the catheter in the vagina to see if urine is coming through the vagina is a nonsense, stupidity. Yes? So obviously it needs to be A. So notice that they tried here because everybody knows, everybody have heard that when this happens, it's okay to leave the catheter in the vagina while you get a new catheter and insert the new catheter above, okay, more toward the pubis, knowing that you should not go so posteriorly as the catheter left in the vagina. And then after getting the proper position inside the bladder, you remove the catheter. The vagina was left there just as a guide to know where not to go. But in this case, they say leave the catheter in the vagina and wait for urine output in 15 minutes. Miracle, miracle, the vagina is peeing. Okay, so it's nonsense. So it's a trap that could, if you don't care, if you don't pay attention but you are reading, you could fall in this trap. A client who is newly diagnosed with hypertension is prescribed Cerebral. Then you know, even if you never heard about this medication, it's Cerebral. What is the most important point to make when teaching the client about this medication? The most important point, you need to make a hierarchization of importance. Notify the healthcare provider if there is a change in your voice. Monitor your blood pressure and pulse regularly. Take medication as directed at the same time every day, even if you feel well. Call your healthcare provider if you develop dry cough.
A as in apple.
Everybody agree? A as in apple? Yes.
Yes.
Okay. What complication are you thinking of?
Angioedema.
No.
Angioedema.
Angioedema.
Okay.
No.
Yes, angioedema. Correct. This is the priority. This is the priority because ABCs, yeah? The cough is annoying but not life-threatening. And it is good to take the medication even if you feel well because the hypertension is the silent killer. You need to take the medication even if you feel okay. And monitoring the pulse is not necessary because this medication doesn't affect the heart rate, but it's not going to harm the client. But the priority is this. A client is NPO and receiving total parenteral nutrition. The nurse recognizes which of the following lab values is important to monitor regularly while the client is receiving the TPN: cholesterol, white blood cells, glucose, hemoglobin, and easy one. Which one is the most important?
Sí, glucose.
Glucose, because it's expected hyperglycemia that would require insulin, even if the client is not diabetic. The client, TPN, frequently requires insulin, even if not diabetic, while in TPN. It is the start of the shift, and the nurse has just finished listening to a report of 4 clients. Which client should the nurse assess first? A client with a diagnosis of acute traumatic brain injury who has a blood pressure of 88/58. A client with a diagnosis of a concussion and who doesn't remember the motor vehicle accident. A client diagnosed with viral meningitis and has signs of meningeal irritation, Kearney-Brudzinski. A client diagnosed with generalized seizures who complains of headache following an observed seizure. What is the priority here?
A.
Okay, the patient with A has a very low blood pressure, and having brain injury is a bad thing. Why? Inside the skull, okay, you have no space for anything. But when you have a head trauma, then you have brain edema because you have shaken brain, brain edema. So the pressure inside the head increases. That's why patient with head trauma make the patient in semi-fowler position to favor the drainage of liquid from the brain. So now the pressure inside is higher than normal, but now the pressure of the blood, to enter inside this closed box that is the skull, need to be adequate to overcome, to be higher than the intracranial pressure. If you have this drop of the blood pressure, having increase of the intracranial pressure is going to be very difficult for the blood through the carotids to enter the skull and enrich the brain, and you can have a severe ischemia in the brain that could be catastrophic. That's why this blood pressure is too low to a patient with a brain injury. Remember that generally in brain injury and increased intracranial pressure, we have the Cushing triad, because the Cushing triad is no more than the compensation that that own brain makes to have a warranty and adequate blood pressure to perfuse the brain. That's why the systolic blood pressure increases in increased intracranial pressure, is to overcome the intracranial pressure and warrant the ¿cómo se llama? The blood flow in the brain. The nurse is admitting a client to an inpatient crisis unit with a diagnosis of acute mania. The client has been placed in seclusion, and it is now time for a client's dinner. What action should the nurse take next? Obtain a contract with the client for safe behavior, serve the client dinner in the seclusion room, allow the client to eat in the dining room, hold the client meal until seclusion is over. What is the right answer?
Sí, professor.
See, I think if the client is needing the seclusion, should not leave the seclusion until is required, is order, is pertinent. So having the client in seclusion has not yet left the seclusion. And taking the client to the dining room with other people present, being in acute mania, is going to be inadequate. So I think that the best option in this case, that the patient needs to be in seclusion, is to serve the dinner in the seclusion room. Once the patient you know, is okay, the patient will leave the seclusion room and could have okay dinner with the rest of the people. But meanwhile, the client needs to be in seclusion because the behavior requires seclusion, and you cannot transfer the client to the dining room. No, I don't know. Are you okay with that? It's not realistic obtaining a contract of good behavior if the client's in acute mania, requiring to be in seclusion. And you cannot hold the client's meal because, you know, please, the clients have the needs of basic needs of feeding. Okay, guys, the last, because it's the last that I prepared for today. The nurse is caring for a client who is admitted for gastrointestinal bleeding. The healthcare provider give an order subcutaneous enoxaparin for DVT prophylaxis. Which action should the nurse take? Ask the nurse supervisor if he agrees with the order, follow the order and administer the medication, page the healthcare provider and clarify the order, verify available protamine sulfate in case of bleeding. What you do?
B.
Guys, the patient was admitted for GI bleeding, and the doctor is ordering an anticoagulant. It makes sense for you? No. So you need to clarify the order with the doctor, because theoretically, a person that is admitted because it's bleeding internally should not be receiving anticoagulant. So you are supposed to clarify the order with the provider. Okay, with the provider. Okay, you know, is like this person that a person is nearby a snake that is poisonous, is a poisonous snake. What should do the person? You know, walk away of the snake or find, you know, the antivenom serum. Having the protamine sulfate in case of bleeding is like, you know, asking for the antivenom serum instead of running away from the snake. Okay, is the same scenario. Okay, it's not a good simile, but you know, trying to build the critical thinking. Okay, guys, this is what I have for you today. Any question?
No, thank you, Professor.
Thank you very much.
Thank you for your attention.
No, thank you, Professor. Thank you.
Okay, so bye-bye. Let me check the attendance. People. Attendance, please. Left.